Thank you, and thank you for staying. I told my wife when I came down here, I said, I think I'm going to be speaking to the other 8 speakers, so I'm pleased that there are 3 more of you that have stayed. Thank you. This picture, and I'll try to be quick so we can get on to the party. This picture here is actually one that really means a lot to me, because this was drawn by the surgeons, one of the surgeons in Mongolia that gave it to us. One of the things that really helped us that I didn't mention in my talk yesterday was going out and wolf hunting with the president of the Mongolian National University of Medical Sciences. It's a big thing to be wolf hunting with them, and this was a thing of how we transfer skills and technology across cultures and countries. I think it says a lot in this thing. I have no disclosures except that sometimes my educational prowess is not very good. When I was a missionary in Thailand years ago, nobody would listen one day, and I finally got fed up and found at least a water buffalo that seemed to listen, but I'm not sure we made a lot of progress. So as we think about education and where education and MIS is going to go over the next while, I'm going to talk in much broader terms, because I think we've heard about some phenomenal thinking out of the box ways to try to expand MIS, but we still have problems. The world is handicapped by some preconceived notions that surgical care is too expensive to implement in low middle income countries when competing with other types of interventions to improve health. I think Eduardo's kind of referred to that as, well, the government doesn't care. Well, the government has so many things to care about, and maybe they don't care, but we have COVID going on. We have clean water and sanitation. We've got robbers along the roadside. We have all sorts of other problems. So I took Sandro Cantini, a friend of mine from Italy, to teach in Mongolia one year. I'd been out to Hoved, and so I thought I'd send him out to Hoved this next year. And I went somewhere else. We got back to the capital city and said, Ray, thank you for taking me to Mongolia. To Hoved, you've now confirmed what I thought. We should never be teaching laparoscopy here. I said, what? I says, yeah, we shouldn't be teaching it here. They didn't know how to put in a chest tube. They didn't know how to do sterile technique. And I said, well, yeah, but did you teach them? Laparoscopy was just a tool to get inside. And so what I didn't understand, that he wrote an article 10 months before he came called Should Laparoscopic Cholecystectomy Be Practiced in the Developing World? We have challenges even with our own surgical society wondering, should we be doing this? In Twitter just this last week, there's an article that's published in Journal of Surgery, and they tweeted, standard laparoscopy remains the routine approach to cholecystectomy was the name of the article. What is your opinion? I went through all the different ways. Standard lap chole, single incision, needleless or needlescopic surgery, small incision cholecystectomy, open cholecystectomy. But the tweet in return from Africa, many of our African nations unfortunately still don't even have basic laparoscopic equipment, let alone skilled surgeons in the field. Trying to improve, we shall get there. So I was asked to talk about how, really talk about a call to arms about MIS in training around the world. I looked up what a call to arms means. Now, I'm not going to talk about the first one, a summons to engage in active hostilities, although I've thought about that sometimes. Number 2 is what I think, a summons, invitation, or appeal to undertake a particular cause of action, maybe like a political call to arms. Well, I think this call is, as has been mentioned in this meeting, to surgical societies, to academia, to NGOs, government, industry, and funders, because without all these, it is not going to happen. I think Jim Kim, when he was president of the World Bank, said it very well. We have to think in a fundamentally different way about healthcare and surgery's role in it. Not only is improving access to surgery the right thing to do morally, but it is also important to ending extreme poverty and boosting shared prosperity. How do we get involved with this greater vision of what surgery can do, and not just surgery, but laparoscopic surgery? Because when we look at the Copenhagen Consensus of 2012, now this included 4 Nobel Prize winning laureates from economics. They asked the question, what is the smartest way, if you had $75 billion to invest that, what are the top 10 things we should do? And number 8 on their list was strengthening surgical capacity. When I was in Haiti, there was no surgical capacity. working in Mongolia. It's been amazing to watch in the last 15 to 20 years, the growth of surgical capacity and actually what laparoscopy had to do with that now that they're doing liver transplants. Their comment was, you gave us the vision that we could go ahead and do liver transplants because we could go ahead and do something high-tech like laparoscopy. In that Copenhagen consensus, it also said, rather than improve access just to essential surgery, there's a case for a broader intervention that improves access to a broad range of healthcare services that may be highly beneficial to poor people. Not just, suturing a laceration, not just doing a tubal ligation, but really much more high-tech things like laparoscopy. When we look at what's happened in the world in the last, this is 18 years, about 20 years, of the change from low to middle to high-income countries, there's been a dramatic increase in upper middle income and high income countries, much more fewer low income countries. What does this do? Well, this gives business markets in rural areas previously thought to be unattractive financially are proving to be a realistic source for economic growth, both locally and abroad. When we look at the global market overview for laparoscopic surgery, about 4.4 million laparoscopic surgeries are done per year in the US. Worldwide, about 7.5 million, but most of these are done in the US and Europe. There's a need, there's a market for about 50 million more cases per year. How are we going to make that happen? In Mongolia, it wasn't just about teaching laparoscopy. It was certainly teaching laparoscopy, but it was also bringing in the political system. It was bringing in the industry. It was bringing in the population that when we first got there said, I don't want to have those little holes. I want the doctor to open up a big hole and put their hand in. I don't believe they can see it through those little holes. We had to go ahead and educate the population as well. The infrastructure development of helping them not just get the equipment, but how do they maintain it? How do they teach the people to be able to maintain it? This is all a critical aspect. And then this information can be used on an international level for funding as well. When I'm talking about large organizations, the Lancet Commission in Global Surgery in 2015 came out. They used one of our small articles to make a very significant statement. One of the small articles looking at the development of laparoscopic surgery in Mongolia showed an 8.9% increase in surgical output. And they suggested that if low and middle income countries, 88 of them, could increase their surgical care and we could help fund them $300 to $420 billion, it would offset a $12 trillion loss, which then had the Lancet Commission in Global Surgery make this statement: scale up of surgical care should be viewed as an investment, not a cost. What I'm trying to point out is that getting laparoscopic surgery, it's fantastic. We have these educational products. We have a spot in Uganda with a phenomenal hospital. We have telemedicine. But to get 50 million more cases around the world is going to take even some greater thinking. One of the things, when I was the vice chair of the Global Initiative for Emergency Essential Surgical Care for the WHO, we had one of our committees look at the whether or not there's any evidence in the literature that surgery helps strengthen surgical systems. And we published a whole article. You know what the article said? There weren't any papers that said that. Yeah, it's amazing what you can get published. And so as you look at this, though, we begin to push this issue of health system strengthening, how laparoscopy can strengthen the health system. I mean, these are the things that we can use with hospital directors, with governments, that it can be an impetus to create new financing mechanisms, provide an avenue for poverty reduction, stimulates infrastructure development, decreases brain drain, opportunity to treat a broader range of diseases, encourages affordable, high-quality innovations. It actually helps improve universal health care. It strengthens the health care system. How can we gain the information and use that to lobby for the things that we need to go forward? In Mongolia, they asked for, how are we going to set up more of a training program? I said, well, how are you going to fund it? So we met with the Ministry of Finance. We met with the Ministry of Education. What you're talking about is really a significant system to train surgeons in the whole entire region. So we looked at the Ministry of Finance asked for a proposal. We were able to work with the Ministry of Health and identified that about 40,000, at least 40 to 70,000 Mongolians seek care abroad every year. It's a loss of about $100 million in local revenues not captured, plus expenditures abroad, 20% of the total healthcare expenditure of the country. There's money in these countries. Now, what if we could get just 10% of those people to stay in the country? What would that do? That'd bring 10 million back to the country. We made a proposal for developing the Asian Center for Surgical System Strengthening in Mongolia. It cost around $10 to $12 million to be funded through a loan that we helped arrange through a banking system at low cost for the country. Unfortunately, the parliament person that we were working with also was trying to run a coup to chase out the president of the country, and she was on the losing side, and so this has fallen apart. However, we've had requests to really bring this back up with the new government. The university is very excited about it. We've asked for, Honduras has asked for the proposal, Rwanda has asked for a similar proposal. I think we need to think of ways to fund what it is we need to do. This phenomenal collaborative project that was mentioned here of iLap, now changed to GLAP because of Apple. I presume that's why it was changed. Was to standardize training, education, and laparoscopy. What a phenomenal thing, though, to be able to partner with a surgical society in Mexico and a surgical society in the United States. And you see Linda here doing a phenomenal job of teaching. We'll have shown another picture of her in just a minute. Just a heads up, Linda. We've had requests to teach laparoscopy in about every country of the world, but we've been concentrating on some in Ghana, Rwanda, Ethiopia. In these places, they're not quite ready for GLAP because they don't have anybody that knows how to do it yet. So how do we get it there? We've been working, what COVID has done with us at the University of Utah has caused us to develop our online University of Utah basic laparoscopic training course that we hope to start implementing in Hawassa, Ethiopia this next month. I've been working with Hopkins, with a group of students that have been working on trying to develop an app that specifically would provide training in these resource-poor areas where they'd be able to understand and handle the instruments, become aware of the complications, obtain practical hands-on experience through simulation, and receive evaluation on skills, progression, and knowledge. The point is, there's a lot of groups out here trying to think innovatively how they can expand things more rapidly. We learned about AAGS, which I'm excited about. I had many calls about how to set up an academic surgery program. I got tired of all the calls, said, why don't we get together and figure out how we can support each other in developing these programs? And so many of us got together 4 years ago and started this process, and you heard from Nia, who's just been phenomenal in trying to move this forward. But there are other groups, Accreditation Council for International Healthcare Education, developing standardization and implementation of dissemination of clinical and education norms for academic institutional medicine, international medicine. When we look at AAGS, that's kind of what we're trying to do. Can we get together and define, what does it mean to be a global surgery fellow? Can we design some education products together and really help build these programs? You know, there are some significant things that happened in 2015. I mentioned the Lancet Commission in Global Surgery that came out. That's where we get these numbers of 5 billion people that don't have access to timely surgical care. I was able to participate and be one of the Bellagio commissioners when we brought this out. But we also had a resolution that took us 7 years to lobby with the World Health Assembly. This resolution that was passed simply was stating that surgery is part of universal health care. Well, what these things have done is that allowed us to really move forward in helping countries develop national surgical plans. The Harvard group has been working very hard on this, but there's not a lot of laparoscopy in these plans. We need to be able to develop these plans with laparoscopy in mind. And we need to figure out how to get into the positions to have that kind of effect around the world. We currently, as an example in our own government, my afternoon today was spent writing letters to various people in Florida, surgeons in Florida, Lee Newmeyer, who's a good friend, Gib Upchurch. I've been talking to everybody here at this meeting who's from Florida, because we're at the pinnacle of trying to get $100 million attached to some wording in the USAID for funding here in our own US government. We have Senator Rubio from Florida who's bringing this forward, and we're trying to get letters to him from his Florida constituents to say that they would like this. This is to get $100 million to address global surgery issues in system development and to look after or to attack the neglected surgical issues such as cleft palate, non-treated traumatic injuries, hernia. Well, laparoscopy is not listed in there. But this is the way PEPFAR started, which is now, what, $75 billion? We get $100 million, we've got to get laparoscopy in the next one. Well, I'd like to end with this one. How do you not get overwhelmed with the scale of the problem? I was asked in a meeting once. I said, well, you start small, you do a little bit at a time. You find like-minded partner like those in this room, and always keep trying. In Mongolia on the left, we've been very successful. In Ghana, we even published the first 50 laparoscopic cholecystectomies at the second largest teaching hospital in Ghana. It's rarely done in that facility right now because of some of the political challenges and problems with the surgeon that he had. And where we taught in Nigeria, I actually haven't kept up. I'm not sure how it's going on there. So there are good successes, and there are some that are not quite as successful. I think this is it. If we want to change something, we can't let somebody else do it. Change will not come if we wait for some other person or other time. We are the ones we've been waiting for. We are the change that we seek. Now, my last slide, I told Linda, I got one more picture for her. We had ILAP, it was GLAP, yeah, but what we had one more program that we started, and because there's really a lot of work down there, yeah, we started INAP. Thank you very much.